Sorry, we can't do that.
Of course, yes.
And what's your relationship, if you don't mind?
Friends.
No. Carl, you can sit there. Don't worry, I don't need to examine you. You're friends.
Yes.
How are you?
Relatively good, I guess.
Yeah.
I mean, I've been having some minor inconveniences like disorientation and occasional dizziness, but I suppose it's either the Keppra or the glioma itself. So I'm.
But you had 2 seizures since
Yes,
last seen you.
but without passing out.
Yeah. What about work? What's going on?
It will all depend on
On the scan?
what the diagnosis is.
Yeah.
My plan is to switch with American Express to the Madrid center and then connect to the neurosurgeons there with your report, if you can give me
No,
one.
of course we can. But Carl, I'm not sure, and I'm actually glad that you brought a few people because we had a long chat last time, and then I sent you for a functional MRI. Yeah?
Exactly.
And it seems that their perception was that you're not really grasping, you were upset thinking that, are you going to do an operation now? And I was a little bit puzzled, and they were a little bit puzzled, because we've been talking that we found that there is a tumor there, yeah? And the question is going to be, what are we going to do?
Yes.
To try to get as many information as possible before we can make a decision.
Yes.
And whilst this is not unusual for people when they have this diagnosis, yeah, then I was wondering, am I missing something about you, yeah? Whether you really understood what we've been talking about. Are you with me?
Not really.
Okay. You've had that seizure, we did a scan and show an abnormality, and it looks to us that there is a tumor of the brain. You kindly gave us that access to your scans a few years back that you had it in Madrid again.
2016. Yeah.
And unfortunately, the radiologists were unable to get it. I think the password, by the time that it got to
I have a new one now.
Oh, right. I will ask Ruth to try to get it.
I can forward it to her.
Yeah.
If you want.
And so we did the functional MRI, and it was a little bit noisy in a sense. Don't worry. We'll wait. Ruth is. So we'll be looking where the area of abnormality is. Ruth is here.
Hi.
Ruth is going to give you another password.
A new link, yeah.
For
Same password, but new link.
Okay, perfect.
And the functional MRI, we do it just to see, if you move your hand, is going to activate right where the tumor is, because that makes a huge difference as to what we could do. And so it was. We do know that sometimes it doesn't work very well, and we can't rely on that examination as such.
Mm-hmm.
But then you had another scan, and we wanted a short interval and also a scan that it would prepare us potentially for surgery. And unfortunately, it shows that the tumor has already grown a little bit and it changed a little bit.
Wow.
So we are not as relaxed as the first time we've met.
Right.
Yeah. we are actually a bit concerned that maybe this is not a low grade and is potentially something more aggressive.
Right.
For that, you will need a biopsy.
Yeah.
Yeah. And because of the location, we can't do much. We just want to take samples that it will give us a diagnosis.
Yeah.
So that will dictate the oncological treatment after that.
So with the new spectroscopy, I think it was, and perfusion and all that, it was not enough for a diagnosis.
No, they always want a very specific diagnosis. You know, we haven't reached yet the stage where the MRI will tell us exactly what it is.
Right.
You know?
So is there anything that you can already see in the last scans?
Yes. So let me show you. There are two different type of scans that I will want to show you. So this is the first one, and if you remember, we are talking cuts like that, looking from below.
Yeah,
So
it's here.
that's right. Yeah, you can see your eyes here, nose, and back of the head. And as we go up, this is the grey bit is the brain. We want the left side to look the same as the right, and we started to notice some abnormality here.
Yeah.
And as we go up,
Especially
we can see
there.
that one.
Yeah.
Especially that one. Now, this bit of brain controls the movement.
Yeah.
This bit of brain, it controls the sensation on the right hand side of the body. Yeah? And then, apart from this, we looked at this sequence where they gave you the injection. Yeah?
Okay, yeah.
And that's very important because when they give the injection, that substance should stay only in the vessels. It shouldn't go to the brain because it's designed in such a way that it doesn't pass through. And whilst we can see it a little bit and very faint in here, there was no contrast to go in the abnormality. Yeah?
Okay.
Now, the last scan that you've had on the 20th, yeah? So, the same thing, but our impression is this is slightly bulkier,
Okay.
yeah? Fatter, and not as smooth
Yeah.
as the other one, so you can see a little bit of change in the consistency there. And that's again something that gives us a little bit of concern. And then when we gave the contrast, again the substance, yeah, we can see just a little bit of a faint here
Yeah.
of that substance that shouldn't go there.
Right. So it absorbs the substance and it shouldn't.
Correct. And so that gives us an indication that this is potentially an aggressive tumor.
Okay. Is that one of those GMBs or GBMs?
Possibly, yeah, GBM.
Yeah, that's pretty much a death sentence, isn't it?
Well, we can't cure it, but the whole idea is that you will receive treatment that it will prolong your life for as long as possible.
Like 2 years or 1 year?
Well, it varies, but yes. I mean, you already read a lot, and you seem to be very astute and knowledgeable about the disease. So it really depends on what it is.
So a biopsy as soon as possible, right?
Yeah, probably in about 2 weeks' time, 10 days' time, something like that.
Is that a procedure that will keep me in hospital for more than a day, or?
Probably 2 days. Probably 2 days, assuming that everything goes well, because actually there is a risk that you may end up with right-sided weakness.
Right.
Yeah. So the plan is going to be, so let's say, I think you need a biopsy. Whether you have it here or in Spain, it doesn't really matter.
Well, but it does matter not to lose a lot of time, right? So if I move to Spain, that will be definitely more than 2 weeks until I connect to new doctors. So I should probably do this now here.
I would strongly advise you to have that here.
Okay.
And whilst sometimes for the biopsies we do just a burr hole, yeah, and pass a needle, in your particular case, I'm afraid we are going to do a bigger opening, yeah, because I want to see how the brain looks like, and we use a lot of monitoring. Excuse me. Hello. I'm with a patient. I'll call you back. And we use a lot of monitoring, neurophysiology, yeah? So we will stimulate bits of the brain and
So
it will
that's-
tell us what
right.
is moving.
So that's one of the wake operations.
It's not awake.
Not
Awake, because we have a very precise monitoring, yeah, of the movement. I tend to use awake when speech is involved, because speech cannot be monitored with needles, yeah? Whereby in your particular case it's only about movement.
Okay.
Yeah. So if wherever I stimulate, yeah, I need to find the place where your arm and your leg doesn't move, and then I can go through that and take a small sample.
Okay.
And also I have to send it to the lab and wait until they tell me that they have a relevant piece of information.
Okay.
Yeah.
Right. I've read somewhere that not even the biopsies are 100% reliable, because one could hit a spot which is not growing inside
That's
the tumor. So
Correct.
what would we do if that happened?
Well, it really depends. Now, when we have low grades, that's why we tend not to do biopsies, and we tend to remove as much as possible, yeah? In your particular case, because of the location, that makes it virtually impossible, yeah? So I'm going to target this area here,
Yeah.
and then I'm going to wait, and if they tell me, yes, it is abnormal, we can give you an answer, but it might take 10 days or whatever, yeah? Then we will stop at that. But if they tell me, well, it's not that clear, then we may take another sample
Right.
and another sample, yeah?
Okay. Okay, yeah. So what's the next step? What would be quite imminent? What do you need from me?
From you, nothing other than we will be bringing you back here to have a pre-admission, to have some bloods taken and listen to your chest and so on, and COVID swabs, yeah? Then somebody will let you know the exact date of the surgery, yeah? And you will be coming in Brighton on the day of the surgery, yeah?
The surgery for the biopsy?
Yes, yeah,
Because there's not going to be a surgery for the tumor itself, because it's...
correct. Because it's in the part of the brain that controls the movement, so there is no point in me removing that part of the brain, because you will be with no movement on the right-hand side of the body, and then you can't have any oncological treatment. So the important thing is to minimize the risk of finding out what it is.
So it is one of those inoperable tumors.
Correct.
Is it, yeah?
Yeah.
Right. Okay. That's life, isn't it?
Yeah, I suppose from one vantage point of view, it is. So there are risks with this operation, yeah. There is a small risk to your life, well under 1%, but it's not zero. There is a risk of me giving you still a deficit, whereby you might not be able to move the right-hand side. It could be the face, it could be the arm, it could be the leg, or it could be the whole thing.
Will I still be able to communicate in any way? Because you said, I think, that the speech and so on was not.
No, but it
affected.
can be if it is the movement of the face or
Yeah, well,
the tongue.
That's not a problem. I
So-
had that, yeah.
People cannot quite express themselves.
I had that already, so that's not a problem. I mean, saying what I, expressing my will and my.
It should not be affected.
Okay.
No.
Okay.
So
Can
the
you-
risk of that is about 2-3%, and there is a small risk of a negative biopsy, as
Okay.
you pointed it out. Yeah.
Would you be able to give me a report that, although it doesn't predict anything, but would it be able? Could you include the statistical outcome of these kind of tumors for me to share with?
The answer is no, because we don't know what it is. Once that we find out exactly what it is, then yes, because otherwise we can bark at the wrong tree. Yeah, I mean, it's still a possibility. Yeah, that this will be still a low grade. Yeah, unlikely, but it's still a possibility. We've had low grades; they took up the contrast. There is a possibility whereby this might be a grade 3. Yeah. So again,
As opposed to.
a grade 4.
Okay.
Which is the GBM. Yeah. So it's a big difference in terms of statistics with the treatment and survival. Yeah. Between them.
Yes.
Yeah.
Right. Okay. It's going to be a bit tricky in terms of coverage, I guess, because this having been spotted before my move, I suppose I'm going to be on the NHS no matter if I have a job or not.
Yes.
But I'm not entirely sure how this works, because in theory, after the 30th of June, I'm working for American Express in Madrid, but I think I should be still on the NHS, right? Or would
Yes.
I have to cover that?
No.
No, I don't think so. No. But there is also there is another thing, Carl. So, for instance, if we have a diagnosis, yeah, then you might be able to move to Spain and have the treatment, the oncological treatment there, assuming that you remain very well, and that will be my expectation. Yeah, my expectation will be that it's not inconceivable that the next day I will send you home. Yeah.
Okay.
And you know the result takes a bit of time. Our lab is in London, yeah, and so it will take a little bit of time for that to come back to us. And once that we have it, then I will tell you what it is, and then the oncologists are going to see you and discuss with you, and they will be in a better position to talk about the statistics and so on. Now, usually for the oncological treatment to receive, it takes quite a number of weeks, yeah, probably 6 weeks at the minimum, because you want to have the wound properly healed, and they do a lot of planning, yeah, particularly for the radiotherapy. So that potentially could be done in Spain, should you wish to do that. But equally, it can be done here.
Okay, but from when on do you think I will be able to have a clear diagnosis from the point you get the results from the biopsy?
Probably 10 days. Probably 10 days. That's the most likely, yeah?
Is that 10 days after the operation?
Yes.
The procedure?
Yes. Yes.
Okay.
Sometimes it takes longer when they are not sure, so they do other tests and we do a lot of the samples. We send them actually to Germany, to Heidelberg. But for your particular one, I don't envisage that will be the case. Yeah, everything will be done in London, but sometimes it can take a little bit longer. Sometimes it could be quicker if they are absolutely certain. Yeah. It could be that they give it to us earlier, and even if you do not have all the molecular subtypes, if it doesn't make a difference to the treatment that the oncologist will plan for you, then we will tell you earlier so we can start the plan.
Right, okay. That's interesting.
Can I just ask, if it is an actual glioma, we're looking at a level 3 glioma, the oncology treatments, is there a sequence of events going from sort of a low-grade treatment, radiology, to
Higher grade, yeah.
chemical induced whatever? How does that work, that part?
Well, it really depends on what it is. So it would be radiotherapy followed by chemotherapy, and it depends on which chemotherapy.
Okay.
Whereby for a grade 4 it will be concomitant, both of them at the same time.
Yes.
For the low grade it might be only one or the other.
Right.
Yeah, either radiotherapy or chemotherapy.
Mm-hmm.
But it depends on the pathology and genetic molecular things that they will be looking at.
But
In the outcomes, then we'll be looking, at years rather than months, and
Yes.
more years and so on. So
Absolutely.
when we look at those discussions, I think it's very important, and obviously the oncologist will be very very keen to have the specific diagnosis, because otherwise the treatment might be inefficient, and the oncological treatment, it's not without side effects, so we can't give you a treatment blindly.
yeah.
And no matter what we think, it's only the pathology that can tell us what it is. Yeah.
Okay, but for now, you do tend to think it looks like a grade 4, yeah?
Potentially.
It looks to you like it is,
Well,
a 50-50
Not yet, but from somebody where we have a short interval scan, that we see those changes, it gives us the concern that it will be a grade 4.
Okay, so you are now referring to the changes within the last month, not the changes from 2016 to
Correct.
today.
Correct.
So even that short period was already
Yes.
remarkable, yeah?
Yes. Yeah.
Okay. But I will still send you that link, right,
Yes,
to the
yeah.
2016.
Yes,
Yeah.
please.
It will be useful. It's not going to change what we are going to do, but it will be a useful feedback for us. Yeah.
Okay. Right, that's that's interesting. I guess your job is to give bad news most of the time, so it's not easy for you either, right?
No, it's not. But that's why we're here. You know, we're here to support you.
Should I be preparing for like left-handed things, like
There is
exercises, or
no. I think we should be fine. I mean,
if there is not another violent seizure, could I continue to be fine for?
yeah,
For
that's
the time
whole
being?
idea. The whole idea. Over 90%, you
So
will
should-
be as good as you are.
So I shouldn't be preparing for anything,
No.
or
No.
changing the Keppra if I'm not suicidal or anything,
No.
because I'm not.
No.
So.
No.
Okay. Because I think we mentioned there are alternatives, but I'm a bit wary about the interim period until I get used to the new one, you know.
It's a good idea now to change that.
Yeah.
We know that Keppra is a good drug,
Yeah.
and so if you have other problems, we just go up on it rather than change. Because when you change the chemical, sometimes, you know.
There may be a seizure.
Exactly.
That's what I meant. So yeah, I prefer to have the side effects of the Keppra.
Yeah.
Do you think there is like some kind of leeway or room upwards
Yeah.
if we have to with the Keppra, the dosage?
Yeah, it can go to 1,500 twice a day. At the moment, we are on 750.
Yes,
So
that's correct.
virtually we can double it,
Yeah.
but we don't go to that extreme. Yeah?
Should I stay taking it every 12 hours, or can I do 500 and 8 hours, 500, 8 hours? Does
No,
that?
twice a day is
Okay.
probably the best.
So there's no benefit in doing.
No, the pharmacodynamic is as such that, you know, it will cover the 24 hours,
Okay.
12 hours, yeah.
Yeah. Right. Well, can you give me any more information about this kind of situation? Because
Not much, and actually,
my whole list of questions has, gone out of the window with.
yeah. Well, and in all fairness, probably for me, the most important thing to convey to you and for you to focus on is the fact that, okay, we found the abnormality, yeah? We need to find out what it is, and the first step is to do a biopsy. And I don't want you to start to think or read. You'll get very confused, because it is confusing, it's confusing even for doctors when they read.
Yes.
And each avenue can take you to a forest.
I know.
So it's very,
I've
can be quite daunting when you
I
start
know.
to do that.
I've tried to keep it to a minimum and to the most medical or academical level. Is there a way of speeding up the biopsy, or do I have to sign anything? Or?
No, unfortunately I'm away next week. So yeah.
You are the one who is doing the biopsy.
Yeah, it will be me. I mean, I suppose I can ask John. So we are three of us.
Yeah.
And one is already on holiday, and he will be on holiday next week as well. I'm off next week, so it will be only one colleague of mine, Giles Critchley. I can ask him to see whether he can accommodate next week, but it is unlikely. Yeah, he's got his own patients as well, so.
Okay.
So my plan would be.
Could you still
for,
try?
Yes,
maybe?
of course. Yes, of course. My plan would be for the 6th of June. Yeah.
Okay.
Which is the Monday after the bank holiday. Yeah. That will be the master plan if that works.
Okay.
But I will ask Giles. The trouble is Giles is operating on Friday, so I'm not sure if he'll be able to achieve much. No, it's bank holiday next week. No, sorry. I mean, it's even not worth discussing, because he's operating on Fridays. The other two are operating on Fridays. I'm operating on Monday, and next Friday is the
Jubilee.
Jubilee. Yeah.
So it would be you on the 6th of June.
Correct.
Okay. And for today, will I get something in writing as
I
well?
will dictate a letter. It's going to be very brief, just to say I will acknowledge the fact that you've had 2 further seizures, that you are on Keppra, what the scan shows,
Yeah.
and what we have proposed, and the fact that you have agreed to go ahead and have the biopsy
Yeah.
next week,
Yeah.
in 10 days' time.
Yeah. Okay. Okay.
You've got me, and I'm away, but Katie, my colleague, so the same email address, the same
Same
phone
email.
numbers.
Okay.
So there will be someone there if you need anything at all. Let us know.
That's good to know. Thank you very much. And thank you for,
That's all right.
for your
I'm sorry I
frankness
couldn't give you better news, and it was a bit unexpected from our part as well, but
Do
we
you
have to
think-
deal with that.
Do you think, considering that 2016 scan and the sudden seizures, that you have, or we have, identified it or picked it up relatively soon or late or in time?
It almost doesn't matter. I think it's on time, you know. It's you can't say that it is a big one. It's just the location, you know, that makes it challenging. And because it was in that location, you had the seizures, because it's the part of the brain that controls the motor movement. So a lot of people will have deeper, 5 times bigger, with no symptoms at all. Yeah. So that was the first manifestation, and in actual fact, with the low grade, 80% their first presentation is a seizure.
Yeah.
Yeah.
Okay.
So it doesn't.
So considering it is growing, should I be expecting some further seizure at some point before going up with the Keppra? Or can
I would say.
can I be confident that with
Yeah.
that Keppra I won't be having a seizure as violent as the first 2 ones?
Yeah, it's a good dose. Yeah, it's a fair dose, 750. So I wouldn't go higher than that. Yeah, unless you have another seizure. But it's a pretty good dose.
Okay, good.
This is the kind of dose that we give the patients when we put them to sleep to operate on them.
Okay.
Yeah.
Right.
So yeah, it's a fair dose.
Okay, thank you very much. And
It's all right, Carl.
are we expecting news?
Yeah.
And I send you a link straight away after this.
Yeah, perfect.
So we can give it to the radiologist and we'll put it on fax.
Because I have it ready in my inbox to send it off. I don't know where my. Can you call me?
Yeah.
Or should we do this in the waiting room?
Yes.
It's in your pocket.
Yeah.